Big welcome to everyone here. My name is Lawrence. I will be your moderator tonight. Jeff is going to be your facilitator tonight. I am a cancer survivor for a number of years. Actually, and I'm not going to get into a whole bunch, but I will go back in time here. Our support group that we have here in Regina started back in 1994 is the original dates as to when we got going. I have been a member of this group since 2007. That's probably where I'm going to leave mine for right now. Do have some experience with helping those out that are looking for some peer sharing. Our group does not provide any medical information to you. That is not what we are here to do. We are only here to provide you with knowledge that we have and can share our own stories. So some of you know me, some don't, and that's okay too. I think for housekeeping for tonight, what we will do is Robert is going to be our facilitator for the online, and Jeff and I and Tammy will actually look after everybody within this room tonight at some point. For housekeeping, I'm going to ask that we would respect one another's privacy. So those that are in this room tonight, if you do have something that you do share, it is to stay within this room, everyone else, for confidentiality. And washrooms, probably the most important thing for many of us, is directly out and into the hallway down to my right, and then turn left, and there's the washrooms. I was asked tonight a little bit about parking. When you come to the in-person, we can park anywhere. We would just accessible to the south door.
Okay, thank you. Thank you very much, Lawrence. Jean, can you bring up the first slide? And it's really it's coming.
I'm just going to have Jeff do an introduction of yourself, if that's okay.
Sure.
Okay. Myra is a partner of Jean, and so she's been married to Jean for 53 years. She's a parent of their 2 adult children, has been a teacher and language consultant, a school administrator, a curriculum writer for the province, a tenured University of Regina instructor, a caregiver of aging parent with dementia, and a leader of the Prairie Peony Society in Western Canada. Her research work in education has been based on both qualitative and quantitative study designs, which informed her search for answers to understanding prostate cancer. So Myra is giving the presentation on what it's like to be a partner. And Myra.
Sorry, Myra, just to interrupt for just a moment before we start. Those that are here and online, Myra's presentation is actually going to be recorded. So if you ask a question, it will be recorded. All of this presentation is being uploaded to YouTube. And those that are familiar with YouTube, it remains on YouTube for an extended period of time. So if you do not wish to ask a question, you may want to think about that tonight too. So the other thing that I want to do just before we have Myra start, I want to do a land acknowledgement because we do have other folks that will actually be coming on to YouTube at some point. So the land acknowledgement that we as a support group have adopted is as South Saskatchewan Prostate Cancer Support Group, we gather tonight on the Treaty 4 territory, the ancestral and traditional territory of the Cree, Saulteaux, Nakota, as well as the homelands of the Métis, Dakota, and Lakota. We pay our respects to the First Nation and Métis ancestors of this place and we commit to move forward in truth, reconciliation, and collaboration with Indigenous nations. Okay, Myra, I will turn it to you.
Okay, Jean, can you share the content with us? And we're going to get our first slide up. My presentation is actually called Killing Klingons. And, you just have to laugh sometimes because things can get very hard. And what we want to do is try to lighten it up a little bit. And so there we go. And
You must
have what, record mode. We want to really focus on a theme that sort of helped us through the year. And what can I say? Beam me up, Scotty. I'll get to the Killing Klingons in a minute. And everybody already heard about me, so we can slip through slide 3 and go on to slide 4. That has been introduced. Okay, so no, slide 3. So back one.
Go back.
Yeah.
How do I do that?
Anyway, I'll just continue. I just want to insert a little caveat here. As was mentioned, I've got experience with research, but I'm not a medical practitioner at all. And I want to make you aware that I have no medical background or training. But my main purpose was finding answers. And so that's what I've been spending most of my year doing. And as many of you are aware, prostate cancer is a partner disease and a family disease because it really affects us all. So going on to 2023, which is when we started, this was the most impactful year for me because all kinds of things were happening. I had a very close friend of mine died from leukemia, and then 7 weeks later, my brother-in-law passed away, and another friend passed away from breast cancer, and yet another friend's husband was diagnosed with metastatic prostate cancer. And I'm sure you've heard the statistics before that 1 in 8 men are affected, and last year 247,100 people in Canada had were diagnosed with cancer. So now at this particular stage, next slide please, of our journey, we didn't really know too much about it, but I really want to say that things started to unfold very quickly once they happened. And I'm just going to tell you about what I felt, what I did, and basically what I learned. So Gene had his PSA jump very high. It was at 7.1, and that was just high normal. And then all of a sudden it just flipped right up to 9.1. It's suspicious but not dangerous. But his his health was good, and I thought to myself, oh, all is good. It's just good to get things checked out, right? And at the time, we didn't know very much about PSA numbers and other important parameters associated with them. For example, the velocity, like, the speed of, PSA rise, the density, that's PSA volume when compared to prostate volume. And lastly, and, this was new to us too, the amount of PSA bound to carrier proteins as opposed to the PSA that was free floating in the bloodstream. So all of that was new, and Gene was very good because he was collecting data all the way through it. And there we have Bones keeping on with our Star Trek. And, we would often talk about this. We would refer to, the war against cancer as, a Star Trek kind of thing. But wouldn't it be nice to be 100 years or more into the future where you could detect cancer, and diagnose it, and then come up with a solution right away. Well, unfortunately, we aren't nearly at that point yet, and researchers have been working now for over 70 years trying to find a cure for cancer. Next slide. And this is where it all started, actually. The biopsy was done on October 25th, and infection set away a few days later. Now, it's a good thing that this actually happened when it did, because our family doctor didn't fool around with waiting on Jean's urologist, because Jean was so adamant about having a biopsy, and also the jump in PSA was so fast, just 2 full points. And so it's actually our doctor, our family doctor, that took the initiative on this. We met with our navigator nurse on the 23rd of November, and we were shown 2 readings of 5 + 4 = 9 Gleason score. And I don't know if you know about this, some of you do, some of you may not, but it's a little chart that they'll show you, and it'll show you all about your biopsy. And all of these numbers and colors on the Gleason chart just sort of flashed up into my eyes, and I felt very, I felt very beside myself, because I just didn't know what all of this meant. And the diagnosis actually had happened on Jean's birthday, but here we are now in late October and into November, taking a look at what these people are telling us. Now, the family doctor sent us to a surgeon who is also an oncologist, and he's very well respected. Doctors say that they wish he were in Regina, but he's in Moose Jaw, mainly because his family is there. His name is Dr. Huang, and he's very well versed in using a machine that uses ultrasound combined with transductors, and this gives live imaging of tumors as they operate. Dr. Huang has 2 fellowships from American universities and has been trained there and has trained other people there. But Jean said, "Oh dear, he looks so young." And I said, "Well, he's got to be in his 40s based on, all his background." And at the time, I thought what Jean said might have been an interesting comment, but on Jean's part, it was, I think, more or less an intuitive thing, because, based on what a doctor's age is or what he looks like, it shouldn't be, your guiding factor. But in our case, it actually was. Dr. Huang sat pretty close on the fence for treatment. He said, "We're going to go for 45% surgery and 55% radiology." And because we asked his opinion, what would you do? What would you recommend a family member do? And so I thought that was pretty close to sitting on the fence. And anyway, he recommended that if we wanted radiology, he actually could have got us in for surgery in 2 weeks, but he recommended radiology if that's the direction we were headed. And he sent us to Dr. Amjad, which was a very, I think, fortuitous kind of happening for us, because Dr. Amjad has been just great. Next slide, 2003 to January. Okay, all through December, I wondered what was taking so long to get an appointment to see Dr. Amjad. And I was frustrated, and I was a little bit angry. Finally, we got a telephone call on December the 28th, and they said, "Well, can you come in on Monday. That was like 4 days later. And we said, well, we're in New Brunswick right now, and we, we didn't really know what was going on, but Dr. Amjad said that when we saw him actually on the 9th, that the pathologist had confirmed signet cell adenocarcinoma, which is a very rare cancer, and it's an aggressive cancer. And Gene was staged at an intermediate unfavorable cancer, C, which means only half of the prostate, and the tumor size was T, which was fairly large, and B was advanced. So, but the happy part of it all was that there was no metastatic spread to it, no spread to the lymph nodes or to the bones. So that was very good. Now, we knew nothing about any of these proposed strategies, but decided to follow Dr. Amjad's plan. People say, wow, this really moved fast for you. I said it did. It seemed like it took forever. Next slide. And so the plan was, we met with Dr. Amjad, discussed what was going to happen, and he said, okay, here's how it's going to go. And I was just shaking as he talked about this. He said, we're going to use 3 multimodal therapies, and they're basically going to have in and around the same time. First of all, we're going to put Gene on ADT. I had no idea what that meant. It's actually androgen deprivation therapy, and it means that it turns off the production of testosterone in your body. And then it was going to be followed by a brachytherapy, which is a surgery that uses radioactive pins put into the prostate. And then after a week of testing, there would be external radiation for 23 days. Now, Dr. Amjad did say, such a kind man, and he always seems to tell you the way it is. He said he was cautiously optimistic, and to me, that was a very good sign. We still didn't know enough about this, though, and it was obvious that we needed to move very quickly on this because it was such an aggressive cancer. And Gene had been convinced that he had prostate cancer all along since as far back as 2020, even before it mutated. So, next slide, please. January to March, you got it? Okay, so we joined the prostate cancer Regina support group on January 10th. And I felt like I had come home to family because Lawrence spoke to me on the phone, invited us to a meeting. James talked to us after the meeting and asked how he could help. Then Moses was in one of our breakout groups, and he gave glowing reports of Dr. Amjad. Jeff and Boyd made us feel very welcome at coffee time. So you can just see how giving these people are, and hats off to all of you. And the partners in my support group were fantastic. Lisa texted, Cindy called, email, and texted. Cinta called and met with Cindy and me, and then Lori called, texted, emailed a whole bunch of times, and she kept me going to meetings, and that was the most important part of it. I don't know how I would have functioned without that, and I actually felt embraced. So you're all such good people, and hats off to you for what you do. Okay, so now starting the ADT, the androgen deprivation therapy, when the testosterone is shut off, that was administered on January 17th by a traveling nurse who came right to our house. And I waited and Jean waited, and there didn't seem to be many side effects visible in the short term, but that's normal. In the shot was Zoladex, which is the trade name for Goselerin, and it is an agonist and an agonist, I mean, and it is it basically functions like estrogen. It takes away a lot of the effects of testosterone, and then partway through the period, Jean also had to take Casodex, which is the trade name for bicalutamide, which is an antagonist, okay? And this immediately shuts off any testosterone bounce that can come about. So it was actually, you know, interesting the way we looked at all these different pills and all the instructions and stuff. We really didn't know what was going on. We attended, though, a week after that, an androgen deprivation therapy session on January 25th. And that session was designed by the famous Dr. Wasserberg, who has written a book of the same title, ADT. And this session was offered at the Saskatchewan agency, the Saskatchewan Cancer Agency, where we're sitting right today. And I was asking questions. I did not realize the seriousness of taking ADT, and I was becoming angrier with what seemed to me were the delays. We got to meet our social worker after the meeting, and she got us set up, and she asked to speak to anyone in our family who was having difficulty, and you know, made recommendations and listened to what they were saying. And she had some very good advice. She said, just take one day at a time. Lawrence also prompted me on the information on the SAS Cancer portal. And this information on prostate cancer is very, very useful. If you haven't been there yet, I strongly advise it. Then what I started doing was reading and researching all winter. Next slide. And here's where I started. I got a basic reading list, and these books came in the mail. They had just been recently published a couple of months prior. And you know, you're going to say to me probably, hey, wait a minute, isn't our oncologist supposed to be doing the reading? And yes, they are, and yes, they will. But let's be honest, doctors are really busy people. They don't have time to do all that reading. And so anything that you come up with and ask your doctor about, if they don't know the answer, that will send them to the right place. So it's our questions that are really the most important thing. So if you have time to read currently, widely, and deeply, that's how you can help your partner and your oncologist at the same time. And you will know the terminology and the studies. So starting off with the first book, just simply Prostate Cancer, Dr. Saad and McCormack at the University of Montreal were the authors at the first one. Very easy to read, great photos, great diagrams. The next book, Dr. Walsh's Guide to Surviving Prostate Cancer. He's a surgeon and a prostate cancer survivor, and he's into the 6th edition of his book. And in this edition, he wrote it with 2 specialists who are really focused on ADT and also metastatic cancer. And so they talk about all the pros and cons of each kind of treatment, which is great. And now I was beginning to understand things. They have glossaries of terms, and anybody who wants to know more about cancer will find it there. It's a big, thick book, and it'll take you ages to get through it, but I advise people just to go to the chapter that focuses on the treatment first, and then go to the start. Now slide next 13. Oh yeah, there's the prostate cancer pathway. This is the one Lawrence put me onto. It really, takes you places that, you will need the information from. So it also advises on wait times, which was very helpful to us, and new cancer patients, especially prostate cancer information. Okay, next slide. Now, this is further reading and research. Qualitative research I knew all about. Quantitative, and it's all numbers oriented. Qualitative is based on themes or commonalities that appear in the research. Now, conventional therapies, most people know that surgery is one, chemo is another, radiation is another, and ADT is another. So those are the very conventional ones. But we are starting to see more complementary therapies, which can involve treatments that tailor the treatment to the individual. So possibly genetics, mind, body, psychological support, lifestyle modifications, even vaccines. There are vaccines now for prostate cancer, and also a whole bunch of immunology drugs that are brand new, but they've finally been FDA approved, and they take advantage of the person's own immune system in order to help kill cancer cells. So they're doing great work on this at the University of Texas, the Cancer Research Institute, and they're done with a lot of their studies. So there are patients actually getting treatment using these technologies. Now, slide 12 is the next one. Now, immunology is the one of the biggest things. And here's what I learned. And, it took me a while to wrap my head around this, but these are looked at as complementary treatments. Because cancer is considered to be more or less an immune disease rather than the conventional theory of cancer cells gone wild, this is all about the body's immune system that has a larger part to play in many cancers than anybody ever thought before. So as I mentioned earlier, there are prostate vaccines. Prevenge is now approved by the FDA. There are checkpoint inhibitors. Now, what is this? They prevent cells from stopping when the cell tries to get rid of something that is looked at as a foreign body or a virus or whatever. Now, checkpoint inhibitors stop the T cells from doing that. And when the body says, should I kill this foreign body or not, because it looks like suspiciously like my own body, what should I do? Well, Keytruda and Jemperli, both FDA approved, are drugs that permit this to happen. Now, CAR T is another interesting method, and they're using this at Princess Margaret Hospital in Toronto quite a bit. And I read a lot about this. It's all about collecting the material out of the patient's body via the bloodstream, and taking it to the lab, modifying it, and then allowing the cells to be modified. And if you've ever seen those pictures of the COVID virus, you can see those little spikes on top. Well, what they will do is they will modify the genetic uh, looks of the cell, and they will add these little spikes to enable the T cell to act against this tumor and the cancer cells. So now, there's been a 25% to 50% rate to longer lasting emissions with these. Now, ACT is the next one. It's a method that is used to get the second set of cells. In other words, when the first set of cells stop working and the cancer cells go after them very aggressively, then ACT is supplementary T cells that they get the body's immune system start working again. Okay, next slide. Stacking is all about using more than one therapy at the same time. So they're using some of these therapies or treatments in conjunction with one another at the same time, not one after another. And there's also dietary changes such as calorie reduction and ketogenics, which lower insulin. And this is something brand new. They never believed that this would ever have influenced things, but actually insulin can spur the growth of cancer cells. And low body insulin reduces the glucose that's available to these cells to continue to grow, and you don't want cancer cells growing. And Dr. Longo, Dr. Mukherjee, and Dr. Cantley, Dr. Mukherjee is a Nobel Prize winner. He is working on this right now, and they're having really good success with it in trials. Next slide. Okay, so now I want to talk a little bit about Dr. Turner's qualitative study at UCLA. She interviewed 1,000 patients. So this is not about numbers. This is about patients and how they felt and how they reacted to certain ways of changing their lifestyles. And Dr. Turner is she's an oncologist that combines the conventional style of treatment with some of the newer styles of treatment. And so these were the commonalities that she found out in 1,000 patients, and she's still finding more patients. Like even after, the paper was written and everything, she discovered all of this. And she found that personal and extensive research on your own can actually help you out. And they're not sure how, but perhaps together with your oncologist, this spurs something on. Proactive in choice of treatments, as Gene was, he was very insistent that he have the radiation. People that relied heavily on social support, just as the support groups and the partners groups here in Regina do. Made dietary changes, like, stopped eating red meat and actually ate foods that were more natural and had fewer chemicals in them. I mean, it's hard to find foods that don't have any chemicals in them as it is right now, but they tried to eat as clean as they could. And vigorous exercise regimes and increasing positive emotions. So that was all part of it. Now, Dr. Wei Wang, he's a senior author at Harvard Medical School. He did a study on her qualitative study, which seems a bit backwards, but anyway, it's how they decided to do it at Harvard. And he found out that many of these commonalities were actually confirmed by the numbers. And he said, while overall results are positive and promising, we want to do a larger randomized control trial that would be valuable for identifying the patients in a certain cancer group. So they're doing more research based on her study. And so we'll find out, what happens with that. Now, stay tuned on these new developments. Now, how did I find all of this out? I actually went down the rabbit hole quite deeply, and Google Scholar took me there. And so Google Scholar will give you all kinds of research information, articles, theses, books, abstracts, publishers' information, professional societies, and on and on. And even websites such as the Mayo Clinic, which is a very well-respected website that's available for general public use. But this gives you access to a lot of information without having to have a subscription to a university library portal. So this was a valuable tool to me. Next. Okay, so by the time I'd done most of my reading, spring arrived. And we found that Jean's PSA was at 1.2. And we'd spent a winter watching what we ate and, being very careful. And this was just amazing because he was at 9.2 and it fell to 7.2. And then finally, when he actually got a chance to have a test, they found it to be at 1.2. So then it was time to do his brachytherapy surgery. So April the 1st, pre-op was undertaken, and they check all parts of you to see if everything's working okay. But they found an irregularity in his heart, atrial fibrillation, and this was a total surprise to us. And we can only say that it was the ADT that helped bring it along. But they put him on, they were going to put him on the medication later on after his brachy because they didn't want any clots, appearing. So April the 1st pre-op, April the 3rd brachy, April the 4th in the evening, he was back in emergency because of extensive blood clots in his urine. And really, he wasn't urinating all that well. And we finally got to the emergency. But I have a little story to tell you about the emergency at the Pasqua. We got to the Pasqua at about 6 p.m. the next day because of, as I said, passing blood clots. I was supposed to have been at a partner support meeting, so my support group started calling and texting. Where are you? What's going on? They volunteered to come to the hospital. We'll bring you something to eat. We'll sit with you if you like. I said, well, there's nowhere to sit. Like this place is just crammed full. And what can we do to help? Well, nothing really, unless then the light came on. I told one of the women what she could do to help. Could you please come over to the Pasqua and just throw a stink bomb in the waiting room just to get everybody out so we can get in faster? Well, what do you mean, no? But we are still laughing over that one because it was just so darn funny. And we stayed at the Pasqua, and it turned out the stink bomb was actually the best method to get in, but we didn't get in to see a doctor until 2 o'clock in the morning. you know, this helped get us through is what I'm trying to say. The support groups were wonderful. And support groups here, you know, there's one for partners, and, you know, it was all women that were texting me and looking after me and calling me. And you know, they're talking about you and, you know, the wonderful work you do. So thank you very much for your help. Okay, and then let's take a look. And then April 18th, the external radiation was slated to begin. But before I leave this, I just want to go to the next slide, and it'll give you the information that you can do. If you know, if you're here at this presentation, you actually know more about the prostate cancer support group of Regina, but maybe you don't know about the women's or the partners support group. And Laurie Harrison is the person to contact about that. And her email is in red on the screen, and her cell phone number is in is at the bottom in black again. So this is just invaluable information. And honestly, people, it's, you know, it's what got me through. It really is. All right, so moving on. Now, here's what got us through the radiation. When Gene came out of his first treatment, he said, honest, he said, it's just like looking at Klingons shooting laser beams all over the place. And you know, we had this visual, and we'd always talk about this. You know, when he'd come out of our treatment, I'd say to him, do you have, did you kill any Klingons today? And he said, I definitely did. So armed with my new information and terminology, I was asking a lot of questions about Gene's radiation therapy. Now, some of you have been through this, know that every week there's an assessment. And so at the assessment, they ask, you know, do you have any questions? Sometimes there's a doctor, sometimes there's a nurse. And once they couldn't answer one of my questions, so they brought Dr. Amjad down, and he relayed the answers to the questions to Gene. And so we were very well supported there, you know, insofar as explaining how things worked and what was happening. However, caregiving got more difficult as we neared the end of external radiation. Gene was very fatigued, but he finally rang the bell, and that's the next slide. Yay. We hoped it was the last Klingon we zapped. Now, we had a good summer at our peony gardens and at the lake. And we went to the casino a couple of times, and the whole, you know, the rest of the spring and summer was just lovely. And we found that Gene's PSA went down to 0.1 yet again, and we hope it makes it closer down to 0 as possible. On the 12th of September, we had Dr. Amjad in to make a presentation to our group here, and he confirmed many of the studies that I'd been reading about all winter. And Gene will continue with the ADT injections every 3 months until the end of December 2025. So far, so good. There's been a slight maybe weight gain. It's been fluctuating up and down, and the AFib is going along okay, and he's lost some muscle mass, but he'll remain on heart medication for the rest of the duration. And I'm watching these developments in immunology very closely, and I think there's something to that. Because after 70 years, you know, they're discovering things that they had never even thought of considering before. And this is just welcome news to us. Now, what's next? We know that PSMA, which is prostate-specific membrane antigen, and it's a PET scan. The province pays for it, and it's one step up in detection of cancer cells. Now, it's been quite a year and a half, and I'm relieved, and I don't know how I got through this without the support of family, friends, these support groups, you know, and the healthcare professionals who did a wonderful job. But I'm still overcome with grief here and there for the life we once had. It's different now, and that memory hits me at the oddest moments. So at least we know where we're going now, and we feel quite confident. And I'm going to conclude with some of my key takeaways. And they are, so write down, once you're over the shell shock, write down in your Rolodex the names of all professionals and contacts who can help you or who can give you answers, and keep jotting these notes in a journal. That's what Jean did, and I did as well. Next one. Start reading all you can about your partner's prostate cancer, its grading and its staging as identified by the pathologist. And the more you know, the better the questions you'll ask. And number 3, be your partner's best advocate, but at the same time, respect your partner's wishes. This was the hardest for me because Jean didn't want to hear about it, and he just, didn't want to hear something unless it pertained to something that day or that week. And so I had to keep it to myself, but it was a good thing, really, and it kept him really positive, one day at a time. Okay, celebrate both large and small victories. This is a journey, and I'm sure most of you know that, and it's not the destination, and you need to take one day at a time, just the day. If you can get through a day, that's all you need. Next one, accept help and pay it forward. That's what I'm doing tonight. It's not my favorite topic to speak on, but I like to share this with people, and I've come across a few people that needed my help too. So it makes you feel really good if you can help someone else who's been in the same spot you were in. And lastly, keep up to the latest research and keep an open mind about it. There's new drugs coming out all the time. There's new therapies coming out all the time, new methods, and keep up on it, because as I said before, you likely have more time to look through some of this stuff than most doctors do. And but you can't, what you can do is bring it up to your doctor and ask his or her opinion on new treatments that you have read about, and they can give you their opinion on it as well. So last takeaway, live long and prosper, as the famous Mr. Spock would say. And last slide. If you have any questions or comments for either me or Jean, you can ask them now. And Jean?
I'll stop share.